Objectives to really delineate the difference between clearing and optimization. We're going to justify risk assessments. We're going to talk about identifying comorbidities, recognizing the ramification of delaying surgery, and talk about some of the atypical and herbal medication issues that come up and that we should be looking for in the preoperative period. So this is one of my favorite patients that I've consulted on, a gentleman who really kind of left his infiltrating squamous cell carcinoma to its natural history for a little bit too long. So when I met him, he really didn't have the ability to wear his glasses well anymore, and we were asked to do a preoperative evaluation on him. And so we're going to try for the first time our audience response. So let's see how this goes. So what can you tell about the patient from that photo? 1, he needs surgery emergently. 2, his risk of a perioperative cardiac event is greater than 10%. 3, he will need a stress test before we get this surgery done. Or 4, he is not living with a significant other. So that we have 4 choices if we could open up the poll. See how this works. Vote A, B, C, or D. So how many of you voted for D there? Yeah. So he absolutely was not living with anybody. This is a gentleman who was actually known to be the guy who could mow his own lawn, but it was in the middle of winter, so no one had seen him out there mowing his lawn for quite a long time, and he allowed his disease process to go on too long. Then we were asked to clear him for surgery. So here are the options for clearing for surgery. A, as long as he has no active cardiac issues, we can clear him for surgery. B, as long as he has no active cardiac issues and less than 2 risk factors, we can clear him for surgery. C, as long as he has no active cardiac issues and he has moderate to excellent functional capacity, which is greater than 4 METs, we can clear him for surgery. Or D, we never clear patients. Should we try this again, or? So I'm being asked to have you raise hands for now. So anyone for A? Anyone for A? B? C? All right, D? Yay, D, absolutely. So we will not clear him for surgery. We are not air traffic controllers, and even though there is a sequester right now, and we are worried about whether there are air traffic controllers, we can still feel pretty comfortable that 100% of the time, when you are at the airport, your plane should not be taking off when another plane is about to land in the same exact spot. We should expect that 100% of the time. But as good as we are at medicine, we cannot in any way, shape, or form be able to say that the patient we are sending to surgery will not have some sort of event. Even the healthiest patient that you ever meet, there's still a small possibility that they are going to have a cardiac event. So I do not ever use the C word when I am doing my preoperative evaluations. The other C word, just to digress for a moment, that I never use is the consider word. That drives me absolutely batty if I am a consultant. I don't want to tell people to consider. They're asking for my opinion. I tell them what I think should be done, not what they should consider should be done. But anyway, we'll go back to this talk. So we do not clear patients, but we can risk assess them. We should risk assess them, and then we should optimize to get them in the best shape possible to make it through surgery with the least chance of having a perioperative event. So we can find the red flags, the active cardiac conditions, and if there is that active cardiac condition, we can delay surgery. We can evaluate risk, whether it's cardiac risk or pulmonary risk, and you're going to hear a lot about that by other speakers in the next few days. We can optimize new and known comorbidities. So our job should be find those comorbidities that can cause the patient problems during surgery and optimize them for the surgery. We can intervene on potential social issues if we're paying attention to them. Areas that happen all the time, things that happen all the time for patients who are drinking too much before they have their surgery, that if we knew and were able to help them reduce their alcohol intake or their smoking or whatever other social issue might be going on, that we could actually make a difference for them, not only in the perioperative period, but in the period after that as well. Certainly reviewing medications with them. They're over-the-counter medications that sometimes we don't think about, those herbals and atypical medications that can really cause our patients issues in that perioperative period, that if we knew about them, we might be able to make a difference. And then we should certainly not cause any unnecessary delays, and we'll talk about that. So rule out those red flag, I like to call them red flags, but the active cardiac conditions, as the AHA and the ACC call them, and if they have these delay surgeries. So these are things like decompensated heart failure. And when I'm actually seeing patients in the preoperative period, this is one of the things that I absolutely look for, because we can actually do something to get those patients ready for surgery. You'll hear more about this from Dr. Wittstein. We should certainly be looking for significant arrhythmias. Generally don't want to send patients with a rapid ventricular response off to surgery, so easy to look for. Severe valvular disease, probably the time that we get the most echoes, when we're just not sure if the patient has severe valvular disease or not. The unstable coronary syndromes, I think all of us are looking for these and feel comfortable saying, oh my gosh, a patient with an acute coronary syndrome should not be going to surgery right now. And then finally, one that we don't always think about, the patient who just had the stent placed in the last 6 months, the last year, and we are really concerned about having that in-stent thrombosis if we increase the inflammatory milieu that Dr. Dorman was just talking about, and at the same time take away their Plavix and aspirin or whatever platelet inhibitor happens to be used. Now you're going to see more about this Lee Revised Cardiac Risk Index very shortly. But I think this is one of the very helpful things that we can do to be able to give patients a sense of what their risk may be when we are evaluating them preoperatively. The risk assessment drives me a little nuts because the scores of 0, 1, 2, and greater than 3 correlate to class 1, 2, 3, and 4, which drives me a little crazy that they're not exactly the same. But the bottom line is you can get a sense of what their risk is for having a perioperative cardiac event. And of course, even those patients without any risk factors and are sitting in class 1 still have the possibility of having an event of around 0.5%. And again, points out why we do not clear those patients to go to surgery. We tell them what their risk is, and we try to reduce that risk as much as possible. So after estimating the risk, what can we actually do to lower it? And you're going to hear a lot more about this during the conference over the next few days. From the cardiac side, we can optimize heart failure treatment. Maybe we start beta blockers. You're going to hear much more about that. Maybe we start statins, which is one of my favorite interventions. We'll talk more about that. Clonidine is a possibility. Revascularization is a possibility. We'll talk more about that. And then treating hypertension, and you're going to hear more about that in the next few lectures today. From the pulmonary side, optimizing COPD and asthma treatment, and 2 new areas that we don't spend as much time on preoperatively as we should, thinking about patients who may have severe obstructive sleep apnea and could have a real hard time post-op with the anesthesia and with pain medications if left on a floor by themselves in a room by themselves where they stop breathing because they're getting so many opiates post-op, when you didn't think about the possibility that this patient could have severe obstructive sleep apnea, and pulmonary hypertension as well. So what should we be looking at when we are doing the preoperative eval? I think we should check to make sure that these patients do not have any other kind of symptoms by doing a complete review of systems that's going to give us a sense of what their other comorbidities may be, looking for those symptoms for obstructive sleep apnea, looking for symptoms for pulmonary hypertension that maybe in the past we haven't really tried to evaluate quite as much. Certainly whether there's any hemostasis issues that might be coming up with a personal or family history, the possibility of severe anemia, not by necessarily getting a CBC on every patient, but by asking symptoms that might lead us to the idea that the patient has a severe anemia. Certainly, we should know if the patient is pregnant. Certainly, we can figure out if they've had a family history or a personal history of anesthesia problems and make sure that we're helping our anesthesia colleagues to know that that's been going on. Of course, the social issues that sometimes we gloss over, the smoking, the substance abuse, the alcohol history that would be really great to know about, or that benzo history that would be really great to know about before they start to withdraw and you get that call from orthopedics in the middle of the night because the patient's suddenly withdrawing from their alcohol or their benzo that no one asked about. And certainly whether we should be doing preoperative testing for these patients, and you're going to hear a lot more about what preoperative testing makes sense for our patients. So all of this is to then say, should we delay surgery based on what we are finding? And the answer is, for emergent surgery, never should we be delaying because of what the internists are telling you. If you have a patient who has an emergent surgery need, don't ask me to come see the patient. Just take that patient off to surgery. I'm more helpful with the patients who have urgent surgical needs that we might be able to optimize in the next few days before surgery. But generally, it's only those patients who have that active cardiac condition or pulmonary condition that I'm going to be able to do anything in the next few days to really help optimize them. And the bottom line is I should not be delaying surgery with unnecessary tests that are not going to help the patient and are only going to make things worse because we are delaying surgery. And there's pretty good data about what happens when we delay surgery. And then elective surgery, yeah, we should be ordering tests for specific indications, and you're going to hear later from Dr. Barinholtz more about this. So what are some of the consequences of the in-hospital surgery delay? So delays for elective CABG, colon resection, and lung resection are associated with a significant increase in infection complications and mortality. And I don't need to remind you guys of this. You guys see this all the time with patients who are just sitting there waiting for surgery, who are sitting in an inflammatory state from whatever their problem was that just brought them into the hospital, whether they broke a hip, whether they're having appendicitis, whatever it is, inflammatory state where then they're lying there waiting for that DVT to develop. You have that Foley catheter in them and they're just waiting for that UTI to happen, and all because the patient is just being delayed by us because we're doing more tests that they don't really need to have done. Hip fracture repair delayed greater than 48 hours, there's a 41% increased odds of a 30-day mortality and a 32% increased odds for a delay of greater than 48 hours for an increase in odds in 1-year mortality. And of course, this is a lot of observational data, and a lot of it probably has to do with the sicker patients are the ones who are having the delays anyway. But it is still some information to take into consideration when you're trying to decide what is the optimal time to get that patient to surgery. Communication, I think, is one of the really key important parts of all of this, and where we have, I think, all of us have fallen down in the past. So what is it that the internist wants to know when we're doing the preoperative evaluation in clinic or in the hospital? Well, we want to kind of get a sense of what the length of the surgery might be and what the bleeding risks and the fluid shifts might be like. How hard is it going to be for this patient? What might be the planned anesthesia approach, and has the surgeon and the anesthesiologist discussed the risks and benefits with the patient? Here's what the anesthesiologists and surgeons do not want to know from me. You don't want to know from me what type of anesthesia I think they should have. I'm not going to presume to tell you what anesthesia that patient should have, and you shouldn't be getting that sort of information from the internist. That is why you guys train to do this. What I can tell you is what I think their risk will be of having an event during the perioperative period. And then finally, we should be clarifying all of this between each other. We should have very open communication avenues between the surgeons, the anesthesiologists, and the internists or family docs who are helping to take care of these patients in the community or in the hospital. Just want to see a show of hands. In the last year, how many of you have been involved in cases that have had a co-management kind of style between the surgeons and anesthesiologists and an internist or family doc for patients in the hospital? So hands up if you've been involved in a co-management relationship in the last year. That's pretty good. And for no co-management relationship, hands up. All right, so most of you have done some sort of co-management, and it is certainly the trend. And it's sort of a train that's taken off from the station and I don't think is ever going to go back. It has expanded impressively since 1996. In that 10-year period, we saw about 35% of patients hospitalized for common surgical procedures were co-managed by a medicine physician. And that co-management by general physicians has increased 11% per year since from 2001 to 2006. So it is something that is just expanding, and every year more hands go up when I ask this question. Now, most of this is driven by hospitalists, and the question is how important and how useful has it been for patients to have this co-management. And I think all of us can think of times when co-management has been probably very helpful, and there's probably many, many more times when we can think about co-management not really being that helpful. We have to think about the opportunity cost. So if your hospitalist is helping to co-manage on a patient who really didn't need them to co-manage, what are they not doing that they could be doing to be more useful to the hospital system or to the society at large? And how much do we help? How do we pick out the patients who the co-management internist or family practitioner is actually going to be able to improve that patient's care? So I think it has to be selected patients. It shouldn't be all comers that we're helping to co-manage. It should be the patients who have the most comorbidities where we can actually make a difference. We all need to be doing something that's going to be useful to these patients. And we have to decide how we know this is all working. So we could set up these systems, but if we're not affecting any outcomes, then we shouldn't be doing this. So we need to know if it's working. And we have to set up clear expectations when we're co-managing with our surgical and anesthesia colleagues, making sure the communication process is open, making sure that we've defined the scope of practice, who deals with what adverse events after surgery, bad cases of hospitalists getting in over their heads and trying to deal with complications after surgery for complications they should not be trying to deal with. Define the admission policies. You shouldn't be co-managing just because the neurosurgeon doesn't want to wake up at 3 in the morning to admit the patient and so has the hospitalist do it and co-manage that patient. That's not a good reason to co-manage. It should be because we think it's going to help the patient if we have that sort of intervention. And then finally, how are we going to manage the issues that arise, particularly those complications? So for our patient that we saw there at the beginning, I didn't clear that patient for surgery. We were able to talk about the kind of risk factors he had. We ruled out any of the red flag active cardiac conditions. We did not delay surgery for him. There was no reason to delay surgery, although I did restart his statin that, not surprisingly, had been ordered 3 months prior. But while he was sitting there letting his squamous cell grow, he also wasn't taking his statin. So we got that back on board. So remember, all surgeries carry risks. There is no thing as being cleared. The preoperative assessment should be thorough but not create unnecessary delays, should identify all the important issues. We should be able to optimize management and minimize risk. Let's talk a little bit more, and of course communication, really, really important. Let's talk a little bit more about some of the atypical medications that you'll come across when you're doing your preoperative evaluations. So this is not an uncommon scenario. We get our call at 10 p.m. from our orthopedic colleagues who say, please clear our patient. for the 7 a.m. surgery for that hip fracture. And one of my orthopedic colleagues is here, and just a nice shout out. Well, I'm not trying to give you too much trouble. So this is a 60-year-old patient who has moderate depressions and Parkinson's. What do we want to do with that patient's SSRI and the levodopa? So I have four or five choices for you. A, delay surgery for a week and discontinue the antidepressant. B, withhold both meds on the morning of surgery. C, continue both meds through surgery. D, stop the SSRI, but continue the levodopa. Or E, you're just not sure, so you volunteer to take both the meds for the patient. So A, who wants to delay surgery and discontinue the antidepressant? No delaying surgery, great. B, withhold both meds on the morning of surgery. Who wants to withhold both medications? C, who wants to continue both medications through surgery? That's almost everybody. D, we're going to stop the SSRI but continue the levodopa. Anybody? Anybody? 1, 2, okay. Or E, are we going to take the medication for the patient? Few of you. Good. So I'm going to go over the answers now, but generally, for most of these medications, you're going to want to continue them on through surgery. The SSRI, in general, don't discontinue. Now, there are issues with SSRIs where people are concerned about platelet activity and bleeding that may result. I think the only time you're ever going to really be concerned about this is in patients who are going for neurosurgery. That's the only time I would think about discontinuing the SSRI. And if you're going to do that, you're going to need to discontinue it probably weeks in advance to make sure that they don't have any sort of withdrawal syndromes as you stop the SSRI. You're not going to want to do this a day or two before surgery. And of course, the balance of all of this is, are you going to have them decompensate from a psychiatric standpoint at the same time that they're going through the stress of surgery, just for the hopeful thought that they might not bleed as much? So I am inside the camp of let's keep that SSRI going to make sure that they don't have that psychiatric decompensation or that withdrawal syndrome. Because I think in general, the bleeding is not going to be a big enough issue. When you do keep the SSRI going, make sure if they start to become hyponatremic that you do think about SIADH as a result of it. If you do withdraw that SSRI, think about the withdrawal kinds of syndromes, the flu-like syndromes, the nausea, vomiting, dizziness, and anxiety that can happen. And then if you do keep it going, think about the serotonin syndrome that might result if you start adding on other meds that can combine with it. So serotonin syndrome, your mental status changes, your restlessness, myoclonus, the hyperreflexia, the diaphoresis that you can see in these patients. TCAs, again, generally don't discontinue these medications. They can also have withdrawal syndromes if withheld, and they may actually have some arrhythmias in conjunction with some of the anesthesia, which is why people would consider discontinuing. But in general, you're going to keep these medications going, especially if they're at high doses. MAO inhibitors, these are medications that I am not going to stop until I discuss it with the patient's psychiatrist. You do not see that many patients on MAO inhibitors anymore, and if they are on an MAO inhibitor, there's probably a good reason why. So talk with that patient's psychiatrist before you stop that MAO inhibitor. Generally, they're held 2 weeks before surgery. Of course, talk with the psychiatrist. And there are two types of reactions associated with this, an excitatory reaction and a depressive reaction as you are withdrawing the MAOs, and then symptoms that may result. There are some of the medications, of course, that we want to avoid if the patient is on an MAO inhibitor. Levodopa, carbidopa, again, medications that you don't want to discontinue very abruptly. differing opinions about these medications, but if you are discontinuing, make sure you're working with the patient's neurologist as you're getting rid of them. Acute discontinuation can cause a neuroleptic malignant-like syndrome, and then of course worsen their Parkinson's disease. So think about these things if you're going to withdraw it. If you keep it going, there are concerns about hemodynamic changes and arrhythmias, but probably better than the neuroleptic malignant syndrome and their Parkinson's going out of control. And then, of course, the antipsychotic agents that patients may be on that can prolong their QT. And, of course, if they're on benzos and you stop them, the withdrawal syndromes that may happen. This was reported about a year and a half ago, serotonin syndrome from linezolid or methylene blue when given in combination with SSRIs or TCAs or MAO inhibitors. So if you know that you have a patient who is going to have methylene blue or linezolid for some reason, you're going to want to get rid of these medications about 2 weeks ahead before they are exposed to that methylene blue or linezolid. Prozac has a really long half-life, and you're going to want to do that more like 5 weeks ahead of time. And then other medications that you want to think about stopping. We're going to talk a lot more about oral hypoglycemics in my 2 talks about diabetes. NSAIDs, and these are all in your guide, so you can look at these for reference. NSAIDs that you're going to want to think about withholding in the period before surgery, some of them obviously with longer half-lives than others, so that you need to hold for a longer period of time. Herbal medications, all sorts of herbal medications out there that if we don't ask patients about them, we'll never know that they're on them. About a third of patients take herbals, and 70% don't reveal those herbals on forms when they're asked about it, so you really specifically need to ask, are you on herbal medications? Are you on any of those medications you get at a place like GNC? Are you taking anything over the counter that we haven't discussed? Make sure you specifically ask about them because they do have ramifications. Herbal medications that you want to discontinue, get them off the ephedra. Get them off any of the Gs, the garlic, the ginkgo, the ginseng, all which have effects on platelets and can have some issues with bleeding. Other herbal medications to think about, kava causes sedation. St. John's wort, oh my gosh, St. John's wort likes to interfere with every other medication through cytochrome P450 pathways, particularly the fact that it induces the pathway and increases the rate of metabolism. So if you have patients on medications like cyclosporin or steroids or midazolam or God forbid, their HIV medications and they're on St. John's wort, messes with all of those and decreases their half-life, gets rid of those medications much more quickly, lowers the levels in the blood. So make sure you're thinking about St. John's wort as well. Valerian, which can potentiate sedation and have withdrawal symptoms similar to benzo, nice to know if they're on the valerian, and echinacea, which also has some immune system abnormalities associated with it. And finally, glucosamine and chondroitin, again, another G that has bleeding risks associated with it. These are all sorts of medications for antiplatelets. I won't discuss this now. You're going to hear a lot more about this, but a nice reference to take a look at. And the cardiovascular medications, which we'll be talking a lot more about in the coming sessions and probably even the next one with Dr. Wittstein. So what we did today, we talked about the difference between clearing and optimizing. We talked about how to do some risk assessment and identifying the comorbidities, recognizing those ramifications of delaying surgery and the fact that we don't want to delay surgery ever unnecessarily, and then hopefully gave you a good overview of some of the atypical and herbal medications that you might come across during that preoperative evaluation.